Hey, good morning, everyone, and welcome to UroNurse. I'm your host, Vic Sinise. We meet here every Saturday at 9 a.m. Central Time. If you're watching this on YouTube, LinkedIn, or Facebook Live, welcome to the show. Hey, for you YouTubers out there, our subscription base keeps growing. You're doing a great job. Keep hitting that button if you have never subscribed before. If this is your first time watching us here on UroNurse, be sure to check out our website at uronurse.com. The best place to go to learn more about the show. We have 54 episodes available on demand at any time. All our past episodes are right on our website, so go there to check them out. Also, we added on UroNurse Plus, a new section that has some additional features. And one of those that's really popular is the audio podcast. So you can listen to this in the audio form on your way to work. So any of your favorite forms of watch or listening to podcasts, go ahead and click those. You'll find us. And if you're not getting our newsletter, please feel free to sign up on our website to get a newsletter. Newsletter comes out every Monday, gives you lots of information about the show. And if you're watching us live, which I know some of you are, be sure to use that comment box. That's how you can send any questions. We're welcoming all questions on any format you use. So this week we host Dean Elterman, who's going to be talking about Optilume. We've been talking about a few different procedures for prostates. So we're going to talk about another one here and really interested in learning about that. And with that, let's go ahead and bring in our expert panel. Hey, welcome, everybody.
Hello.
I'm going to just kick it off here. Let's see here. There we go. I got to read some names up there. Again, my name is Vic Sinise. I'm the host. I've been involved in urology for about 40 years. So long time. Enjoy doing this show and paying it forward to you guys. We always kick off with an introduction and a favorite story. So I'm going to go into my favorite story for today. And it's a little story about perception, because I think sometimes it's important to remember things like that. So I've got 9 grandkids, soon to be 10. And anyway, I've got 6 of them that live in Florida. And we decided we're going to go on a trip to Florida to see them. And I heard about the manatees being at this particular lake. So I thought, well, it might be kind of cool. I'll rent a boat and I'll take the kids and the whole family out. We'll go out on this boat and try to see the manatees. So I did. I tell the grandkids, they're all thrilled. We're going to go out on a boat. So everybody was meeting over there because my son doesn't have room in his car for any more than his 8. So we had 2 different cars. We met over at the dock where the boat was, and the grandkids come piling out. And if I get this picture up here, and here's my one granddaughter who's ready for the boat trip. And I look at her, I said, her name is Molly. I said, Molly, you're kind of dressed up pretty nice for this. Well, she goes, well, Grandpa, we are going on your yacht, right? Perception. She thought that Grandpa had a yacht rented, not a pontoon boat. So I said, you're cute. I like it. But the rest of them were their typical ragtag group. But that's my point, is always remember that people perceive things differently. And one of the things I like to do when I'm doing a prostate biopsy or assisting with that is show the patient at the end of the procedure what that actual sample looks like. Because again, perceptions, people think we're taking these gigantic chunks out of their prostates. And here in reality, it's this little tiny thread. And I think when they see the thread, they're like, oh, okay, then I don't expect I'm going to have a lot of pain later. So always be aware of what perception could be. All right, thanks. Hey, John, how about an introduction? And I know you always have a story for us.
There's no shortage of stories. Anyone who has a life has a story. I'm a private practice urologist in Gilbert, Arizona, who is paying it forward like what Vic is doing by sharing my experience in the business and clinical aspects of medicine to benefit my colleagues. And one of the ways that I'm doing so is by creating the Thriving Urology Practice Facebook group, where currently we have over 2,300 US-based urology practice folks collaborate to improve our practices. And it's all for free. Okay. This is an interesting story. It's kind of surprising to me, actually. I was recently invited to be on a urology podcast. I'll just leave it at that. And the topic was talking about ways to help improve practice's reputation. And what you talked about, Vic, about UroNurse podcast and also perception. is especially germane. We didn't coordinate our stories, but it's interesting how this kind of correlated. Perception is reality to some people. So this podcast, I was very excited because I love this topic, and I've certainly benefited as a practice by maintaining an excellent online reputation, and I teach others how to do this. So I was excited to get on this podcast. So 2 days before the podcast, I tweeted something saying that, hey, I'm really excited to be on this podcast, to be among my colleagues who have been on a podcast. Well, one of the team members on the podcast saw my tweet, and went through my past likes. This person went through my likes. It did not go through what I posted or reposted. Went through what I liked. And this person saw something that he or she did not like. And it was regarding Michelle Obama. And that person did not like what I hearted on Twitter. One day before the podcast, I received an email saying, hey, you know what? We have to cancel you because one of the engineers has something happen. And then I received an email from the co-founder and CEO saying that, hey, do you have a moment to chat? Obviously, I was disappointed because my goal now, I work for fun now. And my goal is really to share information to benefit everyone else so they could elevate everyone. As they say, rising tide lifts all ships, right? So that's what I try to do. So imagine my disappointment that I can't share the message. I spoke with the CEO and co-founder, and the bottom line is they had a Slack channel, and they were discussing the situation, how this one person saw something that I hearted and did not agree with them. So in essence, I was literally canceled on this podcast because I hearted something that did not align with their ideology. So why am I telling you this? Number one, I want to share with you that you want to judge people by the merits of their work. Meritocracy, that's what matters. And not whether or not they align with your political ideology. So check your own biases. Number two, as a leader, as a CEO of that podcast, you need to lead. And in this case, you need to lead by telling your team members that their actions do not serve your audience. They do not serve your audience. They're preventing their audience lose out on the ability to learn valuable information about how to grow their practices. Put aside your differences. Imagine if you lived your life discriminating against everyone who doesn't believe what you believe. That's really sad. Anyway, I leave you with that. Back to you, Vic.
Yeah, that's a interesting story. I guess we all kind of hear about this cancel culture, but sometimes it actually hits personal. I never would imagine someone looking at your likes. Now, I got to admit, I don't like too much, so maybe that's good. All right. Well, let's bring in our guest panelist, Dean. Welcome to the show. Why don't you tell us a little bit about yourself? If you've got a favorite story you want to share. If not, we'll bring you in your presentation. Go ahead, Dean.
That's great. Well, Vic, thanks very much for having me on UroNurse podcast today. It's a pleasure. I'm an academic urologist at the University of Toronto. I work at the Toronto General Hospital and the Princess Margaret Cancer Centre. So these are the largest academic hospitals in the whole country of Canada. So they're really, really big medical centers. And I specialize in functional urology. So mostly overactive bladder, neuromodulation, and BPH, specifically new technologies in BPH. So I trained here. I'm a Canadian urologist. I did a fellowship at Memorial Sloan Kettering and Cornell, both in New York. So I have a little bit of experience working in both systems. And of course, I'm very involved with international urology in terms of guidelines and presentations, etc. So when you asked me to come on the podcast, I was very excited to be able to join you. And this morning when you said, well, do you have a story? We all have a lot of stories. Some of them are PG, some of them are a little bit more saucy in the world of urology. But I have actually a really sweet story, and it reminds me, I was actually just talking to this person. So I have actually one of my closest friends, and it turned out that he was my patient. And it's a sweet story because of the way we met. I was a first-year resident at the Toronto General Hospital. This guy comes in, we're the exact same age, born in the same month, and he comes in with a testicular mass. And it's a Friday afternoon before a weekend, and he's there with not himself, but his fiance and a whole bunch of family. And it turns out that he's getting married that very weekend. And so all of the family is in from out of town, and they're very excited, but very worried. And we thought, well, go ahead, have your wedding this weekend, come back on Monday, and we'll do your orchidectomy. And so there was obviously a lot of emotion happening here. And so I saw him on the Friday, I saw him on the Monday. Fast forward to when I'm the chief resident. I come back my very first day back as a chief resident, PGY5 at Toronto General Hospital. First operation of the day, who is it? It's the same guy getting rolled in for his retroperitoneal lymph node dissection, RPLND. And he saw me and he grabbed my hand, he just started crying. And he's like, it's a sign that after 5 years, you're my surgeon again, and we're connected. And so we've had this bond ever since, and we've become really good friends. This was over 15 years ago. And, he's got kids that are the same age as my kids, and we live in Toronto. And it's just one of those things where lives meet and your paths cross. And I think that's one of the amazing things about being in medicine. What we do is we really get to touch people's lives, and often we actually make a real personal connection. So that's one of my really nice, heartwarming urology stories.
That's a great story. One of the things that kind of led to the storytelling is it's just there are so many stories in this business, and some are funny, some are, as you say, heart touching, and it's just neat because we do reach out to people's lives. I mean, that's part of why I think all of us got involved in this. We care, and it's just kind of, I think, really neat to hear those stories. So it's been a very successful part of our show, and thankfully nobody seems to run out of stories. All right, Dean, I'm going to bring up your slides. Hopefully comes up here. All right, let's see here. Swing you over. There we go. And you can control them by your buttons on the computer, forward and backwards. Take it away.
Fantastic. Well, again, thank you for the opportunity to be able to present to your audience in this podcast. And I've been asked to talk about what is really the latest treatment for minimally invasive office-based therapy for BPH, benign prostate enlargement. And this is the Optilume BPH. And so I'm going to go through a little bit of what this technology is, how it works, some of the recent clinical data, and then we'll open it up for questions. So as I said in my introduction, I'm an associate professor of urology at the University of Toronto, trained here in Canada as well as in New York City. And I sit on a number of international guidelines panels. I'm the lead author for the Canadian guidelines for BPH, and have been involved, of course, with the AUA in a number of capacities, teaching courses, doing the podcast for them as well. This is just a little bit of a background here. These are the main hospitals of what's called the University Health Network in Toronto. It's comprised of the top left, the Toronto General Hospital, the Toronto Western Hospital, and the Princess Margaret Cancer Centre. So these are massive medical centers in downtown Toronto, and it's a real privilege to be able to work at the number one public hospital in the world. So a little bit of just in terms of what is Optilume, and for those of you who are staying abreast of the latest in technology in urology, you may have now heard of the Optilume for strictures, and I'm going to talk a little bit about that just to sort of get our heads around what it is that we're doing with the Optilume. So the Optilume stricture device, it actually looks like an angioplasty device, right? It's a balloon that goes over a wire, and it's coated in a medication called paclitaxel. And there have now been a number of peer-reviewed, randomized controlled studies looking at the efficacy of Optilume. And the idea is that instead of doing repeated dilatations, repeated visual internal urethrotomies, DVIU, you're going to be able to put this balloon dilation and open up a stricture, but the secret sauce is really the medication. It's the drug coating of paclitaxel that gets eluted into the freshly opened up scar tissue, absorbed, and it prevents healing. So the idea is that paclitaxel is circumferentially delivered from the surface of the balloon. It is a precision dose of medication, and it is a hydrophobic medication that's absorbed right into the tissue. And so the paclitaxel will remain through the inflammatory, proliferative, and remodeling stages. So essentially a couple days. into the tissue. And so what you're doing with the stricture device is actually putting a very simple guide wire through this very narrow opening. The balloon is deflated and you pass it over the guide wire, and either under direct vision or using fluoroscopy, you can pump it up to a certain level of 10 atmospheres, in fact, and it will break the scar. And then slowly these micro fissures, of course, will be made, and the drug will be delivered in to that freshly opened up tissue. And it's that anti-proliferative property of paclitaxel that prevents scarring from coming down. And so there have been a number of big studies. They've been called the robust studies, robust 1, 2, and 3. They're international studies, North American and United States based. The most recent one was published in the Journal of Urology. And essentially what you're seeing is improvements in IPSS carried forward, improvements in flow. And one of the things that you're also looking at is freedom from repeat intervention. So if you look here at 24 months, it's around 81% of men will still be free from needing another procedure. So you could call that 80% success at 2 years, which is really good. And then at the 4-year follow-up, we're seeing really significant improvements in the flow sustained out, and it's sustained out in terms of their symptom improvement as well. So more than 67% of patients maintained a greater than 50% improvement in their symptoms without needing another treatment at 3 years. So now that we kind of understand what is the balloon, what is that drug coating with paclitaxel, then we can kind of shift our brains over to BPH. And how is this technology actually going to work in an enlarged prostate? So just taking a step back, let's think about BPH in the United States. It is a huge market that is growing, but it is underserved. So here's just some big round numbers. 38 million men in the US will have BPH pathology. 2/3 of them will be unmanaged. These are men who just live with their symptoms, buy herbal remedies over the internet or late night television, and they're not actually going to see a physician. About 1/3 or 12 million men will actually become actively managed. They'll see a family doctor, maybe even get to a urologist. A good cohort, about 1/3 or a quarter, will just be watchful waiting. Their symptoms are bothersome, but not too bad. They're not going to go on medication. About half of those men will actually get onto medication. So we're talking the alpha blockers, the 5-alpha reductase inhibitors, maybe a PD5 like tadalafil. And then there's, of course, going to be a fairly large segment, about nearly 2 million men, who will actually make it to the doctor, make it onto medication, and ultimately fail medication. It doesn't meet their needs, or their symptoms progress, or they have side effects. But of those, we're really only seeing between 300 to 350,000 surgeries for BPH performed per year in the US. So there's a huge number of men, over 1.6 million men, who fall off the back of the truck. They made it to the doctor, they made it on medication, and yet their story ends and they don't make it onto therapy. And so the idea of being able to introduce minimally invasive therapies, and that number, 300, 350,000, includes minimally invasive treatment. That includes TURPs, enucleation, green light laser, PVP, and your urolifts, your Rezooms, your iTind. And so there's a huge need to be able to meet the demand of the number of men in the US feeling symptoms of an enlarged prostate. So why do we even need an alternative to TURP? TURP's been around almost for 100 years. We're going to have a big 100-year celebration in about a decade from now. And well, on the one hand of the spectrum, medications are okay. The risks are fairly mild, generally speaking, but their benefits are fairly modest. And on the other end of the spectrum, things like open prostatectomy, TURP, enucleation, green light, they have much greater benefits, but of course, higher risks associated with them. So the whole idea of MISTs, minimally invasive surgical therapies, has really opened up this middle group, which is greater benefit than medications, but lower risk compared to the transurethral surgeries. And so when you look at all of the different BPH options, as per the AUA guidelines, you can see that prostates come in all sizes and shapes. And different technologies and different approaches are really best or approved for different size prostates. And so you can see the office-based UroLift, Resume, the older Tumped and Tuna, they're really studied at least in prostates between 30 to 80. As prostates get bigger, you're going to go into transurethral surgery. And then, of course, you've got enucleation. You could argue laser, green light, and also aquablation, which is something that we perform. They're really size agnostic. They can do anything. And so we currently have approved in the US 3 different minimally invasive treatments. We have the iTind, which is the temporary implantable nitinol device. It's that little device that you put into the prostate for 5 to 7 days. It expands, it causes ischemia, reshaping of the prostate, and then it's removed. In the middle here, we have Resume, convective water vapor ablation of the prostate. It's a steam treatment to actually kill the cells and open up the prostate. And of course, UroLift, prostatic urethral lift, to really pin back the lobes of the prostate. So when you have your wish list of what you want to do, you want BPH treatments to improve symptoms. They want it to be easy and painless for both the patient and the doctor to perform, rapid symptom improvement, and of course, ideally very safe and very durable. The last thing I would sort of say about when you're selecting patients for a MIST is you have to really talk to them about their expectations and their values. You cannot overpromise. These minimally invasive treatments are not equivalent to a transurethral surgery, but they do preserve sexual function. They're less invasive, less anesthesia, maybe a faster recovery. And so you have to get out from your patient what is important to them. What are their values? What are their expectations? So when you look at the BPH treatment landscape, on the one end, you've got the drugs, medications. On the far end, a little bit more invasive, you've got resection, lasers, aquablation. And then in the middle, you have the MISTs, as we were talking about. And Optilume falls within those MISTs. And in fact, it's an interesting hybrid because it's a medication which is being delivered through a technology. And I think that's very unique, certainly the first of its kind in BPH. And so the current problems, the complications we have with all of the various other BPH treatments are that they can have side effects, intraoperative, postoperative, of course, bleeding, the need for catheterization and CBI, retention rates, risk of incontinence, and sexual dysfunction. And so we're really trying to get away from that to improve the experience of patients. So on my slides here, you can see that whatever you're doing to the prostate, you're either going to cut it, burn it, cook it, laser it, stent it, steam it. All of these treatments are somehow fundamentally changing the prostate. And so now enters Optilume BPH. So this is taking that technology that we had from the stricture device and applying it to the prostate. So it comes in a standard box. And what it's going in that box is going to be a couple components. One is something called the pre-dilation balloon. And number 2 is going to be the drug-coated balloon. And then, of course, there's going to be a pressure gauge to actually increase the pressure by connecting it. So this will become a little bit more clear in a moment. This is what the Optilume balloon looks like. So for those who are just listening, I'll describe it. It's essentially a double balloon. It looks like in the old days, there was actually some double balloon type of Foley catheters. So it's a double balloon and it's inserted into the bladder and then it's pulled back. The furthest balloon is actually going to sit in the bladder and the second more distal balloon is going to sit in the prostate. And it's sort of shaped like a figure 8 or 2 bubbles. And where those 2 balloons meet is where it's going to lock into the bladder neck. And so there were actually balloons designed for BPH called the Dow balloon in the late 1990s. And there was a lot of excitement and fanfare around these balloons. But the problem was that, number one, there was a lot of migration. They would slip forward into the bladder or slip back because they didn't lock into place. And 2, they just didn't have durability because they kind of stretched the prostate, but they didn't fundamentally change it. And of course, there was no drug coating to prevent the prostate from closing down again. So that you can see from this double balloon, you're going to ensure that if it's positioned correctly, which it will be, you're going to have that distal balloon holding it in place in the bladder. The distal balloon will be in the prostate, the proximal balloon will be in the bladder, and it'll expand. And what you're actually getting is an opening of the prostate at the 12 o'clock position. So there's a publication we recently put out in the Canadian Journal of Urology, CJU. They have an excellent series called How I Do It. They're open access. They're free to anyone who wants to go online. You can just type in CJU, How I Do It. And a number of people who've been very involved with me in the evolution of this device have written sort of a nice step-by-step. So if you're interested, you can read that. So The other thing is that it's customizable. In other words, you need to know the distance between the bladder neck and the external sphincter, because these balloons, the balloons for dilation and the balloon that has the drug coating, come in different lengths, because you want to open up the prostate longitudinally from the bladder neck back, so that you can get all of the drug into that anterior commissurotomy that you're making. And so the size of this balloon, just to give you a sense, because everybody listening is from urology, this is a 90 French size balloon. It is a very big balloon. And so you can see that what we do is we position the system so that the first balloon is in the bladder, the second balloon is in the prostate, and it's that second balloon that's being expanded open, causing the prostate to essentially tear and open up at the 12 o'clock position. The prostate is almost like a peach, and it splits open at the top. And I'm not sure if this video is going to play, but essentially it just shows how you position it. And the end effect is this anterior commissurotomy. This is the key to what it's doing. The prostate is not going to split anywhere else. The prostate will naturally cleave where the left lateral lobe and the right lateral lobe meet. And you're going to create this open and essentially raw surface up at the 12 o'clock position using the pre-dilatation balloon, such that when you put in the second balloon, the drug will then be released right into that raw surface. It'll expand it, dilate it, get absorbed in, and prevent it from closing down again. So you're effectively opening up the bladder outlet. You're expanding open the prostate very, very widely. On the left, you can see the positioning at the end of the device is a little blue line, and you're going to have that just poking out through the external sphincter. So the way you position this is actually coming out distally to the external sphincter. You pull back on the double balloon until you see this marker poking itself out through the external sphincter, and then you can inflate the balloon almost a little bit blindly, and you can feel it lock in place. And on the right-hand side, for those who are watching, you can actually see what this anterior commissurotomy looks like. It's this open raw tissue at the 12 o'clock position that's first exposed with the pre-dilatation balloon, and then the medication gets absorbed right into that. There have been a number of studies, the Everest study, the Pinnacle study, and they're going to be doing something called the Peak study. And us in Canada, I'm the PI for something called the Summit study. And so you can see the theme of these trials. So the Everest study was done in Latin America. This was the first study performed in a prospective, multi-center, a non-randomized group of men. The 3-year results have now been presented at the AUA. And so essentially they took a group of men who were fairly symptomatic, prostates between 20 to 80, and they treated them with the Optilume. And here's the 4-year results, essentially showing that at 4 years, you're going to have close to 70% of men responding to the treatment, having a 30% improvement in their symptoms, having at least a 3-point improvement in their IPSS. So that is a very good number to hang your hat on when it comes to a minimally invasive treatment. The other big story when it comes to the Optilume BPH is the amount of improvement we see with flow rates. It is very significant. We're seeing from about an 11-point peak flow to a 18 mils per second sustained out all the way through 4 years. And the post-void residuals, of course, go down commensurately. This paper, the Pinnacle study, which was the pivotal study performed in the United States and Canada, was just on this month's cover of the Journal of Urology. So that's, I think, a pretty big deal, because this is A, very significant paper, and B, BPH studies don't often make it to the very front cover of J Urol. So this is, I think, really speaking to how important this technology and this study really were. So I'm one of the authors, along with my mentor, Steve Kaplan from New York, who was the PI for the study. And we can see here, again, the schematic from the study essentially showing the one balloon sitting in the bladder and the second larger balloon going into the prostate, causing the dilatation and getting that drug coating all the way into the tissue. This was, again, a randomized study, prostates between 20 to 80. There was a very good sham arm in this study. And in fact, 100% of the patients who were in the sham arm thought that they got the treatment. So it was very good in terms of blinding, which we don't often see with every clinical trial. And you can see at the 12 months, there was a very significant difference between the sham improvement that you would placebo effect and the real effect. You could see 76% of the treated men had a clinically significant improvement in their symptoms, which means a 30% improvement in IPSS compared to only a third in the placebo arm. And when we compare this is not a head-to-head, but this is sort of overlapping with the other pivotal studies, Resume, UroLift, and iTind, we see very similar improvements in IPSS at a year. We see a very good improvement in the change in IPSS compared to, say, UroLift or iTind. And when we go forward, we again see a much higher or greater degree of improvement in peak flow, Qmax, compared to some of the other minimally invasive office-based treatments. So again, I think one of the main takeaways is the degree of improvement that you're seeing with the Optilume, perhaps compared to some of the other minimally invasive treatments. Post-void residual, very nicely improved. And the durability, while it's still very early, seems to be very good. That Everest study that goes out to 4 years had a very low retreatment rate compared to some of the other minimally invasive treatments. And of course, the Pinnacle data needs to mature longer as it's only being reported out to 12 months. Another important aspect of these minimally invasive treatments, of course, is sexual function. And as has been seen in some of the other myths, with the Optilume BPH, we see no change in erectile or ejaculatory function, meaning because you're not really destroying any of the tissue around the ejaculatory ducts and the verumontanum, you're going to preserve anterograde ejaculation and, of course, erections. So my main takeaways from the Pinnacle study, which really were the highlight of the recent AUA and this month's JURAL, is that it's a very well-designed study. It was very well executed in terms of the placebo, the sham blinding. And we see a very significant immediate improvement in symptoms. We see an immediate mechanical benefit in terms of opening up the prostate, which shows to be sustained out through 12 months because of its delivery of the paclitaxel. As I said, the real differentiator, I think, is the peak flow, where you're seeing 113% improvement in flow even at a year, with no changes, of course, to erectile or ejaculatory function. And of course, this study is still ongoing for the year 2, 3, 4, 5 follow-up. The last thing I'll do 2 plugs. One is for a decision aid. I'm sure you've had other speakers on your podcast talking about all the different treatments that are now available for BPH. I perform them all. I have a very complicated conversation I have because we have 4 mists and 3 lasers and all these different things. And it can be very challenging. So some colleagues and I have come up with a BPH decision aid, which is, again, freely available on the internet. And you can go with your patient, or you can even have them go through it themselves. And you just have to type in CUA, which is the Canadian Urological Association, like the AUA, CUA BPH Decision Aid. It'll pop up on your browser. It's free to use. And essentially, all you have to do is click in what is the size of your prostate. So your patient will be able to choose 30 to 80, 80 to 150, or greater than 150. And you can even select which technologies you have. So if you only do UroLift, green light, and HoLEP, you can choose those, and then it'll narrow down the decision tree. So that's a really nice thing to use in your practice. And the last thing that I'll plug, and hopefully we'll bring it into the conversation, I'm wearing my Society of Benign Prostatic Disease, the SOBPD. This is a new sub-society of the AUA. It's open to all members, urologists, urology nurses, etc. There's a half-day meeting at the AUA for everyone who's interested in all things BPH. And they also have a standalone meeting, typically September, October every year in Dallas. So for those who are interested in joining the SOBPD, it's a great opportunity to stay with the latest in BPH. So with that, I'll hand it back to our host, and we can continue with some Q&A.
Hey, that was really great. A lot of good questions I think are coming up here. I'm going to bring some of those up on the screen. But I'm going to start off with a question that I didn't see you in your discussion. What anesthesia do you need to use for this?
So in the clinical trial, it was either general anesthetic or mostly conscious sedation. right? So all of the ones that I've performed have just been using propofol. You are still using a rigid scope. No one has really sort of figured out how to do this yet through a flexible scope. We've adapted the iTind. So the iTind was originally going through a rigid scope, and a few of us have sort of come up with a way to introduce it using a ureteral access sheath and a flexible cystoscope. And now the iTind can be done in the office, awake, with a flexible system. And I think it's just a matter of time before we essentially find a way to introduce the Optilume BPH through a flexible system. And then you can have your flexible scope positioned at the external sphincter, and then you may not need any sedation whatsoever. So all of these things evolve over time. The Optilume is actually commercially available in Canada. We have sort of Canadian FDA approval. So I did the first commercial case in the world not too long ago. And we're doing it with conscious sedation just because it's a little bit easier. But again, we'll probably get to a flexible delivery in the near future.
Oh, good. This question came in from Mark Cherney. How does this procedure compare with UroLift, Resume, and green light laser? I know you touched a little bit about those all being minimally invasive. What are your thoughts? I guess maybe throw iTind in there also.
Well, I think the Optilume BPH would still be considered a minimally invasive therapy, a MIST or MIT. It can be done in an office where you're able to give some sedation. The degree of improvement in IPSS, pretty similar. I think it's the flow rate that really separates it a bit. As I said, you're going to see a greater flow rate. And the other thing too, perhaps, will be the time it takes to heal, because you're not using any steam. You're really not doing any puncturing. Perhaps, and this is a little bit more anecdotal, patients start to feel a little bit of a recovery a bit quicker because, again, it's just more of that dilatation. The drug is in, and then you're done.
I'm guessing they probably still have a point where they're kind of miserable for a while before things get better. The burning,
we leave a catheter for 24 to 48 hours, which I think is very reasonable. It's all outpatient. Nobody's admitted for CBI. And I think an element of frequency and dysuria for a week or two afterwards would be entirely expected and reasonable for what we're doing to the prostate. Yes.
I did get a question from Katie Bortel. Taxol is a microtubule stabilizing drug. It induces mitotic arrest, which leads to cell death. Chemotherapy drug, basically, right?
Yes. I mean, paclitaxel is given, it is a chemotherapeutic agent. And the idea is that it will kill cells through this mechanism that Katie just outlined. But of course, it's given intravenously at high doses to kill cancer, whereas this is a very thin, fine layer. And of course, they've done the safety studies to ensure that, they do the pharmacokinetics, pharmacodynamics. They take blood draws at different times. And the amount of drug that actually gets absorbed into the systemic circulation is measured in picomolars. It's tiny. And so you don't have any anti-cancer or systemic effect as you would. There is, I think, a caution about abstaining from unprotected sexual activity for a certain period of time after. And I think that's more of the theoretical risk of paclitaxel mixing with semen. It could be teratogenic or spermogenic. But besides that, there is no harm to the individual patient or their partner.
What about the people in the OR that are dealing with the catheter and stuff? Any risk for them?
Yeah.
Special disposals?
It's as far as I know, again, I think it might go institution to institution, but I'm pretty sure that there's been no special requirements in terms of the handling of this material. Again, because it is such a small amount that it's not the same as when you're working in the cancer ward with large doses of paclitaxel.
Oh, very good. Now, let's see. Susie Swain asks, how long does the procedure take?
Yeah, so I'll tell you exactly. The pre-dilatation is 2 minutes. The dilatation with the drug coating, if I remember correctly, is 7 minutes. And when you do the urethral stricture, it's 10 minutes with just one dilation. So you take 2 minutes, 7 minutes, okay, let's call it 10 minutes. And then essentially what you're doing is you're putting your scope in, you're passing it in, you're putting your scope out, you're putting it alongside, you're positioning it, and you do that 2 times. So realistically, I think somewhere between 15 to 25 minutes is the time it takes. I mean, I think our shortest is probably about 15, 16 minutes. And that includes the necessary 9 or 10 minutes of dilation where you're actually just plus the time it takes to inflate it. So you got to inflate the balloon. Okay, that takes a minute or 2. Then you got to deflate the balloon. That takes like 30 seconds. So when you add those things up, a lot of the procedures actually you're just standing around, right? The balloon's inflated, it's locked in place, and you're chit-chatting in the OR because it's a very passive thing. So I have residents obviously in the hospital, and it's an opportunity for us to talk about pathophysiology, BPH, what is the medication doing? So essentially, once you're inflated and it's held in place, you can kind of just cross your arms and wait for the time to go down.
Oh, very good. David DeVerno, hope I'm not mispronouncing. Any issues with bladder neck insult from the Taxol?
So I think if you're asking about bladder neck stenosis or bladder neck contracture, to my knowledge, no. And the reason is because you're really only creating that anterior commissurotomy. So you're really only splitting open the prostate at 12 o'clock. So maybe at the top is where all the action is taking place. And the absorption of paclitaxel into the healthy tissue really doesn't do anything. It's that area of tissue that's freshly opened up that wants to heal itself, right? It's a cut. And when you have trauma, you've got all of the macrophages and all of that inflammatory response that wants to close up a wound. And it's the paclitaxel that's preventing that wound from closing. But the rest of the prostate from 1 o'clock all the way around the clock to back to 11 is untouched. And so you really won't see any issue with bladder neck contractures or insult.
Well, makes good sense. Monica Friedman asks, this sounds like a great option with fewer side effects than other treatments. I'm curious about longer term studies. I think we all are. We are doing this in our outpatient surgery center. You see this as something potentially that could come to the office then? Or I said you were doing it in a hospital based or outpatient, right?
So first of all of these studies, the Everest study, the Pinnacle study, the Summit study, are designed to have long-term follow-up. We always report the primary endpoints at 12 months, but they are designed to follow patients annually all the way out to 5 years. So we will get longer-term studies. We'll also be able to do real-world studies where we have prospective registries to know how these patients do in the real world. In terms of setting, I mean, I've done these in my, it's the 14th floor of a medical office tower outside of the hospital. We have a little mini, I think what you would call a procedure room. So we've got a little OR table with some stirrups. We're able to give sedation. We're not able to give general anesthetic. So it's sort of like a procedure room that you would have in, I guess, a US urology office. So we've done them in that setting, and it's totally fine. As long as you can give them a little bit of sedation and you've got the urology equipment, scopes, it can be done there.
Good. Susie Swain asks, any BPH patients that wouldn't be a good candidate for this procedure?
So because it's based upon prostatic urethral length, the distance from the bladder neck to the external sphincter, and you have balloons in different sizes, you have to select, do you want, a 3 centimeter, 3.5, 4.5 centimeter. You can't have a prostate that's too short or too long, right? Because you don't want the balloon to go out into the external sphincter. And of course, you don't want the prostate to be too big for the treatment to be done. Now, of course, all of the experience, aside from the very few commercial studies that I've done, have been in the US in a clinical trial setting. So no one has really tried to do this in a 25 gram prostate or a 100 gram prostate. So maybe there'll come a day where maybe I'll use the biggest balloon in a 100 grammer and see how it works. Mm-hmm. The other thing too is, I guess, from an anatomy perspective, it's the middle lobe, right? If you have a very big middle lobe, that causes a lot of obstruction. And it's a contraindication to the iTind, to UroLift. Depending on, there is the middle lobe technique for UroLift, but it has to be amenable to being able to do, to pull it in and tack it down out of the way. I guess the interesting question is, because all the action is up top in the roof at 12 o'clock, I wonder whether with a small to modest middle lobe, whether the Optilume BPH could still work well, because you're really opening up the prostate at 12 o'clock and you're going to improve the flow there. So that remains a little bit to be seen. So maybe it'll open up the opportunity for some men with middle lobes who want a mist, because again, we're opening up opposite to where the middle lobe is.
Very good. Hey, John, I'm going to bring you in here because I know you're the big proponent for treating BPH sooner than later so that we can save those bladders out there. We've all had those horror cases where a patient just can't be fixed.
I like to call us the defenders of the detrusor. We want to intervene sooner so guys are not losing function in their bladders. I tell my patients numerous times, I told them numerous times yesterday, as a matter of fact, I don't really care about your prostate. I worry about your bladder. I'm treating the prostate to preserve, to make sure the bladder continues to work throughout the rest of your lives. And I hate to rain on your parade, Dean. I actually, when I come on a podcast, or if I'm on a live show like this, webinar, if I'm invited to speak, I actually spend the time to do the research. I read the Pinnacle study, and I'm a little disappointed in the outcome. I'm wondering if you guys, the investigators, actually met your endpoint, the desired endpoint. This is great. We can do TURPs. We can demonstrate that the flow is amazing. But perception is reality. How do the patients feel? The difference between the sham arm and the treatment arm in this study was only about 3 points. That's a little disappointing, in my opinion. In addition, when I perform a TURP, I can give the patients the option of whether or not I can perform this procedure as an ejaculation preserving TURP. Not only can I give them the wide open channel, symptomatic improvement, and I'm using bipolar, so minimal to no risk of erectile function. And if you know what you're doing, patients are not going to be incontinent because of an external sphincter injury. So I do this procedure now all as an outpatient. And if they need a catheter, it's less than 24 hours. Some patients I'm doing this procedure on using TURP, bipolar TURP method, I'm doing these tubeless. So it's very difficult for newer technology to impress me when I have such an amazing tool on my tool belt to preserve the patient's bladder function, make him feel better, and not only satisfy my criteria of having a strong flow, but also provide symptomatic improvement. Yes, I understand that even though I can give them a nice opening, not all post-TURP patients are going to have that symptomatic improvement that we desire, just like in this Pinnacle study.
I agree with you, John. I think it comes back to the beginning of the podcast, which is perception and expectations. And there's no arguing that TURP is a versatile and excellent operation. I love doing TURPs. And I love doing lasers. And the one thing is, as I said, values and expectations, you cannot conflate the outcome of a mist with that of a TURP and a resective operating room-based technology. So I totally agree. And more people should learn how to do a middle lobe only TURP or an anterior resection TURP and leave all of the pericollicular tissue, all of the tissue that surrounds the apex and the verumontanum to preserve anterograde ejaculation. We've learned that over the last decade, that in fact, that is the key tissue that you need to preserve to keep ejaculation. And you can get rates of anterograde ejaculation as 95 to 97%, because the risk of retrograde ejaculation with the median lobe only is only about 2.8%, call it 3%. However, I think also it has to do with expectations and perception on the part of the patients. And as I showed you that demographic data in the US, there's not enough urologists to be doing enough TURPs. We just don't have the workforce and we don't have the operating room resources to TURP everybody. And even if every urologist in the United States was adept to do a fantastic ejaculation sparing bipolar TURP, number one, we don't have enough workforce. And number two, patient perception. Not everybody can or wants to go under GA, spinal, run the risks, whatever they are, even they're low. So that's where these myths were really born. They were born out of a need. Things come out not because of an imagination, but it's a desire or a need on the behalf of patients. So I agree with you. The results from any of the myth studies, when you hold them up against TURP, they're always not going to look great.
Well, even if you look at the Pinnacle study by itself, an improvement, IPSS improvement of only 3 points is a little bit disappointing. Would you not agree?
I think that, a clinically significant or clinically meaningful improvement in IPSS has been defined as a 3-point improvement. So that's like when in the AUA symptom score, the AUASI or the IPSS was first developed 30 years ago, that the statistically significant improvement in IPSS is 3 points. So I think what we're reporting in the Pinnacle study is the percentage of men who met that 3-point improvement, which I think is around 60 to 70%, 67%. So some of them will have a greater improvement in 3 points. At least it's 3 points or greater. So I agree. If you're only getting a 3-point improvement, it's marginal. It's statistically significant. It's what's defined as being a meaningful improvement in IPSS, but it's not anything to write home about. I agree. But I think we've also done some really interesting studies looking at patient perception and in terms of BPH surgery and what's important to them. IPSS doesn't matter to patients. In fact, flow rate doesn't matter to patients. It's metrics that we in the world of urology, the doctors and nurses, use because they're at least objective or validated. Patients care about when can they return to work? Will they have pain? Will they have incontinence? How invasive is it, right? So I think it may not be the best surgery. TURP will maybe be a better surgery, but the perception of patients, what they value is the ability to have something minimally invasive, quick return to work without the certain risks. So it's all about, again, expectations, meeting those expectations of our patients. But I'm aligned with you, John. I totally agree that if you look at on face of it, 3 points is not anything to write home about. But a lot of men will be very happy with just that because they've avoided a more invasive surgery or a perceived more invasive surgery.
I think this is in line with how Americans or Canadians or people in general think about saving for the retirement, long-term thinking. TURP has the greatest durability, of course, but it is a little bit more invasive. It has to be done in the operating room. But Optilume requires parenteral anesthesia. You're talking about doing it on your 14th floor procedure room, but it requires propofol. And that is also not without risk, although it is done as an outpatient in the clinic, which is a lot easier and potentially a lot cheaper. This may give you a short-term 3-point IPSS improvement at 1 year, but I am anxious to hear what your thoughts are, what you have seen so far preliminarily in your longer-term study. I know it's not published yet, but longer-term study, because at 1 year, you only have a 3-point improvement. Over time, what is that going to do? So that's going to be interesting to see.
Yeah, I agree. I mean, I think that over time, we'll have to keep an eye on all of these myths. And I think there's two sides to this argument. One is you're kicking the can down the road.
Yes.
And you're ultimately going to need a TURP, and that's okay. And then the other side of that equation is BPH treatment is a stepwise approach to meet the symptoms and the needs of the patient at that time in their life. So watchful waiting is appropriate for some. Going on to medication is appropriate for some. And then let's say someone they're still working, they're sexually active, they're going to want to have maybe a mist. And then 5 or 10 years later, they're going to be ready to do the surgery because, again, it failed and they're going to want to have something that's longer lasting. And maybe they don't care so much about ejaculatory function because now they're perhaps a bit older. So two sides of the coin. One is kicking it down the road, and the other is stepwise approach to BPH as per what the patient needs at that time in their life.
That's right. Shared decision-making is key.
Yeah, I think another point that you pointed out in one of your slides is the undertreatment of BPH. Everybody's willing to go for medications. Why? Because it's simpler. And as we said, perception, I deal with patient education a lot. And you talk to patients about anything that says the word surgery, like a TURP is, their thoughts are, well, I don't want to have an operation. But you start talking about these minimally invasive things, and they start going, well, okay, it's done in the office, and maybe Optilume, I'm sure it's going to get to the point it's going to be an office-based procedure. Is these things, I do a lot of the steam-based and the clipped ones, and patients are more likely to sign up for those than they do for TURP, and we offer all of them. It's just patient's perception. It's got to be simpler if it's not done in a hospital base. And it's office, is more efficient. You can get a patient in and out of there pretty quick. They're not stuck waiting and losing a whole day they do in a hospital. So I think it's good to have more than one tool in your toolbox. And certainly I think we have to keep in mind what patients are asking for, because it's a competitive market too. And one other question I'm going to bring up before we call this a day. Do you have any post-procedural instructions that you often, or that you give patients when they go home?
Typically nothing very special. I mean, they have to look out for the catheter care for the day or two, make sure that they're drinking enough to ensure that if there's any hematuria, that it doesn't clot. And after that, it's just, take it easy, resume normal activities as required. That's about it. Those are the main instructions.
In my mind, I'm thinking Peridium. In my mind, I'm thinking Peridium and antibiotics and encouraging fluid intake and rest. Keep in mind that if you're thinking about bringing this into your office, in your clinic, you're inflating a 90 French balloon in the prostate, 90. So keep that in mind. Anesthesia, I think, is going to be really important.
Yeah. Now, one last joke, or sort of a joker, but it's kind of a true story, is we have a lot of patients that have come into the office bleeding because of home nursing, going in there and inflating the prostate with a balloon in their prostate rather than their bladder. So we've had those happen with that before. So it's been done.
Yeah, this is intentional inflation.
Right, exactly. Well, Dean, I really appreciate your joining us. It was a great talk. We're always interested in learning about these new products, so this has been great. Really appreciate you being here. Just got a little plug for next week. We're going to be talking about the Lumia prostate biopsy system. This was a system in a Uro Connect that was sent to Suna, where somebody had asked, hey, what are you guys using in your office for biopsy sampling? And this one person wrote this in, and I said, I need you on the show to explain that. So she'll be with us next week. So that's how you can become a panelist here. Again, thanks. I want everyone to have a great weekend, or what's left of it. It looks like we got nice weather here in hey, Canada, can you quit sending out your smoke down to us from your forest fires?
Yeah, it's try and keep them under control. Thanks.
All righty. And thanks again, Dean, and John. Always thanks for your help. And we'll see everybody next week.
Thanks, Dean. Thanks, Vic.
Thank you.